Hey everybody, it's Karen Anderson here with Aortic Hope and a very special live Q&A event tonight. Before we get to that, I'm going to ask you to please click like, click subscribe, click that little bell so that you're notified every time we go live and you don't have to try to rely on your memory to get you through our calendars, which are very, very busy and full of wonderful, wonderful events like tonight. And tonight, we're so happy to have Dr. Catarino with us from Cedars-Sinai. I know the last time we were ready to do this, you got pulled into a surgery and these things happen. So we're really appreciative that you took some time out of your night tonight to have this great live event we're going to have. So take a minute, introduce yourself to everybody, and then we'll get started.
Thank you very much, Karen. Thank you for having me. And I'm so sorry about the last time when I was stuck in the OR. So my name's Pedro Catarino. I'm a cardiac surgeon, and I specialize in the aorta, mainly the aorta in the chest, but sometimes I do end up in the abdomen with my vascular colleagues when we do combined operations. I work at Cedars-Sinai, which is a big hospital network in Los Angeles, and I've been here for 5 years. And before that, you might guess from my accent, I worked in England for most of my career. I went to medical school and did all my training there before I moved to LA. And so I'm here to answer any questions you have about the aorta or any part of the aorta. I look forward to this evening.
I can't believe you've already been here 5 years. Why do I feel like I
It's
just
gone in a
met you
flash.
yesterday? That's
Yeah.
insane. That's crazy. So, one of the things we were going to talk about the last time was aortic valve disease. And that's because we were in the midst of this I think it might have been a month or two ago. So, it was big. It was something we were talking about. And so, I want us to talk about what is aortic valve disease. I know part of it you can be born with, and some of it you can develop. So, maybe you can explain the different disease elements.
Okay, well, the first thing to say is the aortic valve is the valve at the base of the aorta. So the heart, the main pumping chamber of the heart, pumps into the aorta, and the heart contracts, and that pushes blood forward, and then the heart has to relax, and to keep your blood pressure, the aortic valve closes. If there wasn't an aortic valve, your blood pressure would go up and then really go down a lot. So when you measure your blood pressure on a blood pressure cuff and you get the top number, that's the pressure when the heart's pumping forward, and the bottom number is the pressure when the aortic valve closes. So the aortic valve is a very important valve. It suffers a lot. It has to open and close with every beat of the heart, and it suffers wear and tear like any part of our body, particularly as we get older and the tissues become less elastic. Then the valve can stiffen up, and that can lead to the valve narrowing, which we
Hmm.
call aortic stenosis. But it can also lead to the valve leaking, which we call aortic regurgitation or sometimes aortic incompetence.
Hmm.
And the most common form of aortic valve disease is that sort of wear and tear, degenerative aortic valve disease.
Which one do
But
you see
as
more often? Is it stenosis or regurgitation?
so stenosis is about 4 out of 5 patients, and
Oh,
then
wow.
1 out of 5 would have regurgitation. And
Okay.
then there's a group of patients who have both, of course,
Mm,
who can have mixed.
okay. Interesting.
And you can be born with either aortic stenosis or aortic
Hmm.
regurgitation. Or
Okay.
otherwise, another thing that's very common is that people are born with 2 leaflets in the aortic valve instead of 3 leaflets,
Right.
and that's called the bicuspid aortic valve. And
Hmm.
about 2 in 100 people have a bicuspid aortic valve.
Okay.
And they're a little bit more prone to both aortic stenosis and
Hmm.
aortic regurgitation.
Okay. Okay. So, how does somebody find out they have something wrong with their valve?
Well, typically they get uh, cardiac symptoms. So
Okay.
there's more load on the heart, and it's similar whether it's a narrowing, aortic stenosis, or the
Hmm.
leakage, aortic regurgitation. They may get short of breath when they
Mm.
exert themselves, so more short of breath than usual,
Hmm.
or they may get chest pain.
Okay.
Sometimes they may even have a fainting episode or pre-fainting.
Hmm.
That's sort of more common with aortic stenosis.
Okay.
And then to compensate and to increase the cardiac output, the heart tends to hold on to fluid, And sometimes you see that fluid, for example, in patients' ankles, they get swelling of their ankles, or
Mm-hmm.
sometimes that fluid on the lungs that can make them short of breath as well.
Mm-hmm.
And then the last symptom to mention is that it can make the heart irritable and they get electrical disturbances.
Mm.
So the rhythm can either be very fast or irregular, and that can come and go.
Okay. And it's any of this hereditary?
So yes, so of
Mm.
course, there's a form of congenital aortic stenosis which is hereditary, and congenital aortic regurgitation. Bicuspid valve isn't hereditary in that sense of
Mm-hmm.
like, a certain proportion of your children would have it if you had it. There's about a 10% correlation. If you have a first degree relative with the bicuspid valve, you
Okay.
have a 10% chance of having it. So
Oh,
there's
okay.
some genetic component, but it's not 100%.
Okay. Okay. So you're feeling a little symptomatic, or you end up having a CT because you're not breathing, something doesn't feel right, and you're saying basically would be found incidental, is what I'm assuming, right? Or they're scheduling a test. Let's take a look and is this something that you can hear when you listen with the stethoscope?
That's right. You can hear it. So this
Hmm.
causes murmurs, and
Gotcha.
there are characteristic murmurs for narrowing, and there are
Okay.
characteristic murmurs for leaks. And so
Okay.
when your doctor listens to your chest, they can pick up a murmur, and then that
Hmm.
typically will lead them to order an echocardiogram.
Okay.
Echo is that test where they put some jelly on your chest and run an ultrasound probe over it, and it
Hmm.
gives a really detailed picture of the heart. And
Okay.
that's how we can tell if somebody has aortic valve disease. And also we can grade the severity of the
Hmm.
heart disease, of the valve disease.
Hmm.
And typically it's graded as mild, moderate, or severe.
Hmm.
And it's really the severe group that end up needing some sort of intervention.
So, unlike an aneurysm, which does not shrink, can issues with your valve change? Can it get a little bit better? Can you go from moderate to moderate to severe? Can you fluctuate in that grade?
No, not
Okay.
really. It's a progressive condition.
Okay.
And the minute you start having even mild stenosis,
Mm-hmm.
you create turbulence across the
Mm-hmm.
valve, and that turbulence is what leads to further loss of elasticity in the valve, and it makes it worse, and it's a sort
Mm-hmm.
of vicious circle. So once you get it, it's it is something that needs to be monitored, and it can be progressive. It doesn't necessarily mean that you're going to have an intervention,
Mm-hmm.
and indeed the heart is very good at compensating for mild and moderate degrees of both stenosis and regurgitation. But it does need to be monitored. Typically, it's 6 monthly echoes to monitor
Okay.
patients. Whereas,
So
with the aorta, it's yearly scans.
yearly.
It's
And
it's
and
much
also
longer.
with the aorta, we all talk about that the CT scan is the golden standard of care. So is it the echo that really is the best way to determine what's going on with the valve?
Yes, it is.
Okay. Okay. Well, that's different, right? Because usually it's something else. That's what we're always doing. So you just talked about treatment. At what point do people need treatment? How do you know when it's time?
So if you have severe either stenosis or regurgitation and you have
Mhm.
symptoms,
Mhm.
then you need treatment.
Okay.
We know that it's definitely beneficial. If you have severe either of them and you don't have symptoms, but you can tell on the echo that the heart is beginning to struggle, and
Mhm.
typically that means it's dilated, then
Mhm.
that we know you need intervention.
Okay.
And there's increasing evidence that maybe we should be intervening even on patients who don't have symptoms but have severe stenosis or regurgitation, because they'll recover more quickly. The
Mm.
heart will recover more quickly. That's really that last statement I made is not as strongly evidence-based, and it's
Okay.
something that is just coming into practice now. But the first two statements that I made about symptoms and evidence of heart dysfunction,
Mhm.
those are strongly evidence-based.
Okay. So what does valve resuspension mean? I've heard that mentioned a lot from people.
Yeah, so that's in a dissection. When you
Okay.
have an aortic dissection, you may get aortic regurgitation, so an aortic leak, because the
Mm-hmm.
dissection disrupts the leaflets of the aortic valve.
Okay.
But when the surgeon comes in and removes the dissection area, and then they put some sutures in to help
Mm-hmm.
pull up the valve again, the
Okay.
dissection is pushed down, usually one of the leaflets. The
Mm-hmm.
surgeon will put sutures in to lift those leaflets up. And that's why we call it resuspension. And
Mm.
that's a form of repairing the aortic valve.
Okay.
So you don't need to replace it. And we know that's better for patients to keep their own valve rather
Mm-hmm.
than to get a prosthetic valve.
All right, so let's talk about the treatment options because now you're just mentioning that resuspending is a form of replacement. So if you have regurgitation, is that something that they can do? Or stenosis, can they just kind of tweak your own natural valve as a form of replacement
Uh,
or repair rather?
so if you have stenosis,
Mm-hmm.
then you can't have a
Okay.
repair. The valve
Okay.
is too damaged and wouldn't give a durable repair. But
Okay.
if you have a leak, if you have regurgitation, it may be possible to repair the valve, and there are various techniques for doing that.
Mm-hmm.
That's quite a specialist procedure. That
Okay.
isn't something that every cardiac surgeon would offer.
Mm.
It would
Okay.
need to be a specialist aortic surgeon who would be
Mm.
offering preserving the native aortic valve in a leak. So
Okay.
typically it comes down to replacing the valve. And there are broadly two ways of replacing the valve.
Mm-hmm.
One is a transcatheter replacement where you put the valve, you compress the valve and you put it up through the artery in your leg, and you feed it up into the aorta and
Mm-hmm.
expand it inside your native valve.
Mm-hmm.
And that's called a TAVR, transcatheter aortic valve replacement.
Right.
And it requires a little bit of sedation and a night in hospital,
Mm-hmm.
and uh, and the recovery is pretty quick. The downside to it is that, well, it's a relatively recent treatment, so the durability is still to be determined,
Mm-hmm.
and it has a slightly higher risk of causing a leak on the valve, of you needing a pacemaker,
Mm-hmm.
or of you having a stroke.
Okay.
The alternative to the transcatheter is to have open heart
Yeah.
surgery, and so that's a big deal. That's a general anesthetic,
Mm-hmm.
some sort of incision in the chest, maybe a
Mm-hmm.
full incision, maybe a minimal incision,
Okay.
but whatever incision, we need to actually stop the heart. And so
Mm-hmm.
that means the patient needs to be connected to a heart-lung machine that supports circulation. And
Okay.
then while the heart is stopped, the valve can be, the native valve is removed and a
Mm-hmm.
new valve is sewn in place, by hand, and then the heart is restarted and the patient taken off the heart-lung machine. And
Okay.
that is typically one night on ICU and another 3 or 4 days in the hospital recovering,
Mm-hmm.
and about 6 weeks to get over the whole operation.
Yeah, that's big.
Uh,
It's big.
and that has a slightly higher mortality that
Mm.
goes with that compared to
Mm-hmm.
the TAVR procedure. It, of course, depends on the underlying risk of the patient, but
Mm-hmm.
the typical risk would be about 1 in 100 chance of having a sort of bad outcome with that.
Okay. I would think also, from what I know, that each procedure is dependent upon the type of valve is dependent upon the procedure. So I think with a TAVR, you can't do mechanical, right? Because it won't compress. Am I right?
Correct. Yeah,
Okay.
exactly.
All right.
Yeah,
So
but I
let's
have a
talk about
couple
the
of
different
valves I could
valves.
show
Yeah.
you.
Show and tell. Show and tell.
So, so why don't I start with a mechanical?
Sure.
Because it's the most weird. It doesn't look like our native valve.
Yeah.
And if you
Yeah.
can
It's
see
got these
that,
doors, like
so
flopping saloon doors.
it's
Yeah.
this is a it's a very old valve. It's been around for many years, many
Mm-hmm.
decades. You can see it's got two leaflets,
Mm-hmm.
and they're made of carbon fiber, highly polished carbon fiber. They're very durable,
Yeah.
so they will last, essentially forever. And you can see that around the black bit, which is the carbon, is a white bit. And
Mm-hmm.
that white bit is a sort of medical grade polyester, and that's what the surgeon actually sutures in
Okay.
place.
Okay.
And you might be able to hear a
Little
sort of
tick,
ticking
tick.
noise. So
Mm-hmm.
one of the things about mechanical valves is patients who have them can hear them tick. Not,
Mm.
if it's normal noise, they can't hear
Mm-hmm.
them, but if everybody's silent, you can hear
Okay.
it like a clock in the room.
Okay.
And so the advantage of these valves is they last a long time, but the disadvantage is that they are unfriendly on the bloodstream,
Mm.
and so blood will clot on that if you
Okay.
don't take regular blood thinners. And in particular, you need to take a blood thinner called warfarin, or some coumadin,
Mm-hmm.
and that can fluctuate in your blood, and so you need blood tests as well as
A lot.
taking the daily medication. So
So the
patients find
trade-off,
that a bit
you have
intrusive.
one for a long time, but you have to have open heart surgery to get it, and then there's a lifetime of possible tick-tocking and blood thinners. So it's
Yes.
right?
But
How do you
it
make that
is, I
decision?
mean, it is, so if you're a young patient,
Mm-hmm.
that's often a very good
Okay.
option. And
Yeah.
by young, I'm really talking about 65 or under.
Okay.
So definitely 60 and under, you probably have a survival advantage having a mechanical valve because it
Mm-hmm.
saves you having another procedure.
Okay.
But so that is a good option.
Mm-hmm.
It's fallen out of popularity, and
Mm-hmm.
maybe it represents 1 in 8 surgical valve replacements at the moment. So
Okay.
the majority, even for open heart surgery valves, are the tissue valves, and they look like
Mm-hmm.
this.
Mm-hmm.
I don't know if you can see it
Yeah.
well, but there are these 3 leaflets, and
Uh-huh.
they look like our native valve. This is
Mm-hmm.
actually a pig valve. It's actually a pig's valve, and it's been mounted on a similar polyester frame that allows the
Mm-hmm.
surgeon to sew it in place. And you can see the leaflets are very thin, very friendly on the bloodstream. Um, that doesn't need you to take any blood thinners,
Okay.
but I can almost see through the leaflets. And
Yeah.
you can imagine that will also suffer wear and tear. And
Mm-hmm.
typically it will last about 15 years, 1 5,
Okay.
in a patient sort of in their 60s or older. If we put them in younger patients who are more active, they tend to degenerate more quickly,
Mm.
maybe even as quickly as 7 or 8 years.
Mm-hmm.
And that's the same sort of valve as a TAVR valve. I haven't actually got a TAVR valve with me, but I've got a similar valve, a similar idea.
Oh,
This is a
okay.
valve that doesn't need, it's a surgical valve, but you can see it's got a cage around it. So
Mm-hmm.
it's designed to be put in without suturing, so it
Oh,
speeds up the
wow.
surgery. So this one is made of cow pericardium. It's a
Mm.
little bit thicker. So it's bovine pericardium, also 3 leaflets.
Mm-hmm.
And I brought this because, like a TAVR, it can be compressed,
Mm.
and that by compressing it, that allows it to be put up the leg and expanded inside. That's how a
Mm-hmm.
TAVR would work. But this particular one is designed to be put in open. But
Now that looks
that
thicker. So does that
it is
last a little bit
thicker.
longer, maybe, or no, the same?
No, it
About the
doesn't.
same.
Yeah,
Yeah.
it's 15 years, I think. That's
Okay.
what I tell patients.
How
And
many
they're
times can you
pretty
do that? How many times can you go up somebody's groin to replace these?
well. You can imagine that it's all about size.
Mm.
Dropped it on
Mm-hmm.
the floor. So you can see the valve I first showed you,
Yeah.
that ring, that orifice has to be
Mm-hmm.
big enough to put another valve inside it.
Right.
So if you get the first valve is big enough, then you
Mm-hmm.
can put a TAVR inside it, and possibly even one inside that. It really depends on the size. If you're a small person, that may not be an option for you.
Okay. Okay.
And one of the
Sweet
issues that we don't
decisions.
often talk about, but with the TAVR going into a valve like this, is that
Mm-hmm.
once you've got 2 of these valves in place, there's a bit of disturbance in the flow around the valve. And so you probably also need to be on blood thinners.
Mm.
So that takes away some of the advantage that you got by avoiding
Right.
the
Yeah.
mechanical option.
Right. Such a personal choice because I listen to you and I want to change my mind because I know I'm going to need it one day and I'm like I will lose my mind if I hear the TikTok. I will become very hyper focused and I don't like blood tests all the time. Although I hear that it's getting easier, you can now test at home. I thought there's a home kit unless I
That's right.
understand that wrong.
Yes, that
So,
there's a finger prick
okay, that's
test, so you
easier,
don't need a formal blood sample drawing.
right? So, and that's a lot, but then again, you don't have to ever have your chest cracked open again. You're done and it's done. You hope, right? Done. I'm sure there could always be risk for complication. But then I think, well, then I can have when I don't have to hear it and I don't need to test. I don't need to be on blood thinners. It'll be quiet, but I'm only 50, going to be 56. So that would be requiring to do another one. And then, by then, if I needed one at 71, that's still young. So it's like, I mean, I don't
Yeah.
there might be a need for a third. And like, are you really going to do it? Or are you just going to say the heck with it? I'm just going to see who outlives, what outlives what first. So it's a hard, I see why people struggle with these decisions.
Yes, there's
That's
not
tough.
one size fits all. It is a
No.
very personal decision.
Yeah.
It's a lot about your lifestyle.
Right. Yeah. But I just love seeing them. I don't think I've ever seen a bovine before in that cage. That's really very interesting. So the bovine is the pericardium. So is that that's the heart muscle in and of itself or the lining? What is, I forget what
So
that
it's
is.
the lining. So the heart comes in a
Okay.
bag, that bag that
Yeah.
allows it to beat smoothly and
Right.
not rub up against things is pericardium. So it's
But
quite
the
a big,
porcine, that's an actual valve. Those are valve tissues.
that's right, yeah.
That's interesting. Do people, I know this seems like a weird question, I've never asked it. Do people ever make decisions based off of any kind of cultural or religious decision?
Yes, no, I've
No?
never had
Okay.
that.
I don't know.
People,
I'm Jewish, so I didn't know.
I've
Is
had
somebody going to
Jewish and
say I
Muslim
can't have
patients
pig?
who won't eat pork, but they would
Right.
accept
Okay. All right.
a
Well, that's
valve,
good to know. I
and
mean,
also Hindu patients who wouldn't eat beef and who'd have a bovine
and
valve.
they have a cow. Okay, that makes sense. But that's still, I think that's an interesting question. I just gave thought for the first time. Let's check in and let's see who's with us, and if anybody has any questions about this section. Before I want to talk about recovery time. Well, let's do that real quick. You did say that if you're going to have the TAVR, it's about like a day in the hospital, and the other one open, you said is about 6 weeks after, because you still have to let the sternum heal, right? Do you
Yeah,
do you
the
get
sternum.
do you do cardiac rehab after that?
Yes, you do.
Okay.
You
So
do.
then you have a cardiac rehab to go through as well.
Yeah.
Okay. All right. So that's
But
that's
most
your
people are
recovery.
ready to go back to work at six
Okay.
weeks, at that point.
Yeah. Now, if all you had, as if it's not enough, but if all you had was aortic valve disease, but you don't have an aneurysm, can you consider yourself when it's fixed, one and done? I'm fixed. I'm finished. I'm not at risk for any issues with my aorta, or are you technically still should be monitored in case something goes wonky with the aorta down the road?
Um, I mean, fixing the valve won't change if you've got a slightly dilated aorta. So if you
Okay.
need monitoring for the slightly dilated aorta, you'll continue to need that
Okay.
monitoring.
Okay.
And so most surgeons would probably replace the aorta. We drop the threshold, so it's 4.5. If you're having a valve operation for the
Mm,
valve, but
okay.
your aorta is 4.5, you have that replaced.
Oh,
Whereas
I
we
didn't know
wouldn't
that.
operate on an aorta just at
Right.
4.5 unless there were extenuating circumstances.
Mm-hmm. Mm-hmm. So you might as well, if you're going to be cracked open, you might as well just go
So
mechanical. You're already there. So just do it all and get it over with. All right. That makes sense. That's interesting. Okay. Josh, who is with us and what do we have as far as questions?
Well, I haven't seen any questions yet.
Oh, okay.
Let's say hi to Velda and Rob and Christina and Molly and Ken, who's joining us from Brisbane, Australia. I
That's
love it
early
when
in the
Ken
morning.
drops in. Yeah.
That's great. That's always very early.
And
Okay.
there is a link to anonymous questions in the chat if anybody wants to ask something without putting their name to it.
Okay.
Carry on.
All right. Thank you so much for going all of that with the valves because I know people want to see it. I know they want to touch it, they want to feel it, they want to look at it, they want to understand it. And I do think visually it helps really get an idea. First of all, just to get an idea on how big the aorta actually is. When you see that valve, you realize um, what it's that door is opening up to, and that's a big vessel. It's pretty big, right? So
Yeah.
I love show and tell. I do. All right. Now we're going to move into the fact or fiction that I talked about with everybody online. These are just going to be quick questions that we see in the community. If you have questions that you want to ask, this is the time to go ahead and put them in the chat below or use that link for the anonymous questions, and we'll ask it for you, of course. But these are questions that we see all the time pop up in the community. And as I was talking to Dr. Catarino before we went live, I just find it fascinating, people's answers, and they're not physicians. And so we're going to get a real answer this time. So I don't know. I haven't read all of them, so just bear with us because you never know what people throw. All right. Fact or fiction, you can only have one dissection. You'll never have another one.
Yeah, I think I'd have to say that that's fiction. And I've treated a patient just last week who had initially a type B dissection.
Mm-hmm.
So that was affecting the aorta that goes down the chest and into the abdomen. It was all the way down.
Mm-hmm.
And they had actually had treatment scheduled for that. And while they were waiting for the treatment for that, they had a type A dissection.
Yeah.
So you can have
This
another
happens.
dissection, or you can have extension of your dissection.
Okay.
So you have a type A initially, and it goes part of the way around, and then that can go further around.
Right.
So yes, I think you can have more than one dissection.
Okay. 5.5 centimeters is the standard for intervention on an aneurysm.
Correct.
Okay. CT is the only standard test with the best results for dissection.
It is. I mean, it is the best. It's the gold standard.
Mm-hmm.
There are other options, particularly MRI is an option, but
Mm-hmm.
because dissection's usually a sort of emergency,
Yeah.
MRI isn't really set up to be done in an emergency. CT is the one that's set up to be done quickly. The test
Mm-hmm.
itself is very quick. So MRI is less commonly done, but it is also a good test. And then the final option is, if you can't have a CT or an MRI, you can have a transesophageal echo, and that's
Mm-hmm.
also a good test for dissection.
Okay. If you have a dissection or you have aortic disease, you shouldn't fly in a plane. I don't mean to giggle, but some of the questions make me laugh.
Yeah, so if you have a stable aneurysm or dissection, then I mean, I let my patients fly.
Mm-hmm.
I encourage them to not take too heavy luggage, and
Mm-hmm.
especially not lift the luggage above their head,
Right.
put it
Right.
in the overhead compartment, because I think that is a very strenuous,
It
like,
is.
exertion. But they can fly,
Dr.
and even
Catarino,
including long flights.
but you have to understand that a woman's suitcase for 2 nights and 3 days is going to average 38 to 42 pounds. Just
Naturally,
saying.
naturally. Well, I'm married, so I know all about that.
You too. Okay. Hey, you just mentioned this lifting overhead. The next one was you really shouldn't lift any weights at all.
So I don't agree with that. And usually, of course, it depends on from patient to patient.
Mm-hmm. Mm-hmm.
But what I usually tell patients is that if they are able to lift weights that they can do repetitions of, then
Mm-hmm.
they can lift the weight. And I even
Right.
encourage it, because I think that sort of going to the gym and lifting weights in that way helps your blood pressure control. And long-term blood pressure control is probably the most important thing that you can do to reduce your risk of an aneurysm getting bigger, or
Mm-hmm.
of a dissection, leading to need an intervention.
Okay. You can never eat salt again if you have aortic disease.
That's very severe.
Right. There's a
So,
tad bit
so,
severe.
so that is, I think that really comes to the question about the blood pressure control.
Mm-hmm.
And, so we all know if you've got high blood pressure, that moderating your salt intake can assist you in controlling your blood pressure. So, that's where that comes in. But I think completely excluding salt would be very severe.
Yeah. Okay. This is one that still exists out there if you Google things that People who have had a dissection have a mortality rate of maybe they get to live anywhere from 5 to 10 years post dissection.
So that's not true. Actually, the long term, there are a lot of studies that look at dissection survivors long term, and um, the survival rates are very good.
Mhm.
Probably 60 to 70% at 10 years, and that's with most of those patients being quite elderly
Mm,
and actually dying of conditions that are not related to their aorta.
okay. Okay. Um, let me see. Okay. Somebody says, my dad and I have high blood pressure. He had an abdominal aneurysm. I had a type A dissection. Could they be related or are they related?
So they could be related.
Hmm.
They're not necessarily related. Abdominal aortic aneurysms are much more a sort of wear and tear disease, and they're related to atherosclerosis, which is that
Hmm.
condition that you get with high lipids in your blood, and all those sort of risk factors like smoking, diabetes, high
Hmm.
blood pressure. And dissections are much more related to a sort of weakness in the aortic wall, some sort of intrinsic weakness,
Hmm.
and not that sort of wear and tear issue that abdominal aortas are. But it is possible they're related. And in fact, we know that if you have an aneurysm in the chest, you have a
Hmm.
10% chance of having an aneurysm in the abdomen.
Oh, okay. That's very interesting. I love learning something new every time. Okay. Upon discovering an enlarged aorta through echocardiogram, a CT with contrast is not necessary.
Oh, I think it is necessary. I
It
mean,
is
that's usually the
necessary.
next step. If that was an
Hmm.
exam question, you'd have to say false.
It would be false. If you have aortic disease or you've had a dissection, you're never going to work again.
That's definitely not true.
Not true.
We know
Not true.
many survivors are very active.
Yeah.
Oh,
You must check your blood pressure every hour or when you feel something that feels off.
yeah, no, I don't agree with that. Actually, I
Hmm.
discourage my patients on checking their blood pressure on those sort of one-off occasions. I'm much
Hmm.
more interested in what is the chronic average blood pressure.
Hmm.
So, if I'd rather that they checked it once every 2 weeks on a Tuesday, I don't know, in the morning,
Hmm.
and they did that, and then I say to them, if you come to my clinic every year with your 26 recordings of what your blood
Mm.
pressure was on that day, then I get a good idea of what your chronic long-term blood pressure is.
Yeah.
And I'm not
Okay.
so interested in the swings that may be
Right.
related to exertion, or whether they are a bit dehydrated and it's low, or I'm interested in the sort of chronic long-term average blood pressure.
Okay. Let's see. Um, Aortic dissection is always associated with chest pain.
No, it's not. It's about 2/3 of cases are associated with chest pain, and 1/3 have some other presentation or
Hmm.
may even be silent.
Yeah, I know people with that. They just felt off. Something
Yeah.
just felt not right, but there was literally no other symptom that they had, but something was not right so much that they knew something was very wrong, if that makes any sense. So, yeah. Um, it is it necessary or not necessary? Or is it common practice to prescribe beta blockers to a patient with an aneurysm and uncontrolled high blood pressure and throws in there for good measure, moderate to severe PVCs? A lot.
So it sounds like there are three indications for the
Yeah.
beta blocker. It's the rhythm disturbance, two is the high blood pressure that's not controlled,
Hmm.
and three is the aneurysm. And
Hmm.
beta blockers do help reduce the rate of expansion, and that's been proven in patients with connective tissue disorder, not proven in other patients, but the
Hmm.
implication that it reduces it in connective tissue disorder is that it would also reduce it in other patients. So it's typically prescribed.
Right.
So that patient probably should go on beta blockers.
And another one in the realm of medications, all patients are prescribed the same medications when you have aortic disease.
No, it's obviously tailored to the individual patient, and of
Yeah.
course, some patients have side effects,
Mm-hmm.
and even there are different medications within each class of medication, and some
Mm-hmm.
patients may have side effects from one medication of the class but not another,
Right.
and so it's often a process of gradually increasing the meds as well,
Mm-hmm.
and it really does vary from patient to patient.
Okay. This person says, I can't even say it without laughing. Whew, if I've been diagnosed with aortic disease, I can never eat a dill pickle again. Obviously, that's
Well, the
fiction.
dill pickles I know are, not enough to
Not enough to
cause
do
any
anything.
further
Okay.
problem.
Anxiety. It's just in your head. Think positive.
Yes, I mean, I'm very much in favor of thinking positive, and
Mm-hmm.
yeah, but I think if you do, you talked about the chest pain and
Mm-hmm.
patients who have aneurysm, and I think if you know you have an aneurysm and that you have chest pain, you should seek help, and you should make your
Mm-hmm.
doctor aware. If it's not your usual doctor, make the doctor aware that you
Yep.
have this aneurysm, because without that, they may be thinking very much along the line of the heart and
Mm-hmm.
then miss the fact it's the aorta, and the treatments are completely different.
Right.
So,
Exactly. Exactly. Um, when you leave the hospital after, let's say, open heart surgery, you can just immediately resume your normal activities, your normal routine.
no, that's not typically the case. I mean, even
Yeah.
if you have a minimally invasive procedure, I wouldn't recommend that you just go straight
Mm-hmm.
back to whatever you were doing. Mostly your heart has recovered really well,
Uh-huh.
and it's some other issue. For example, the incision, the wound
Mm-hmm.
itself, and they're not all down the middle. Sometimes, now, especially with robotic surgery, you get these little incisions on the
Hmm.
side.
Okay.
And but even so, you need to recover from that incision, and that needs to heal up well.
Mm-hmm.
And then if you've been connected to a heart-lung machine, your blood count is usually low. You're anemic because you've had
Mm-hmm.
to have your blood thinned during that heart-lung machine procedure. And so
Right.
your energy levels will be low. And so you need to progressively increase your activity, and
Yeah.
not just go
Jump
straight
right.
back to whatever you're
Right.
doing before.
And talking about activity, fact or fiction, you can never resume anything you did before, such as go to the gym, lift babies, have sex, etc.
No. And
Right.
we have people who fly jet aeroplanes at high Gs
Wow.
after these sort of procedures, and they are okay. So,
Okay.
most of us never experienced that sort of force and acceleration. So you can pretty much do all those activities you mentioned, plus fly
Except
jet planes if you have a license,
I don't do roller coasters. I was told I can't,
or roller
but you
coasters.
know,
Yeah.
but I go on baby coasters, but don't tell my doctor. All right. If you have aortic disease, then you have a connective tissue disorder.
No, probably not. And I say that, I said probably not because there are likely to be many conditions that we don't know about
Mm-hmm.
yet. And if you have had aortic disease and you're young, you may have had one of these genetic screens, which is
Mm-hmm.
looking for some molecular pattern that we know is associated with aortic disease, but they only pick up about half of cases, and it's
Okay.
likely that there are another half that we just don't know what the actual mechanism is, or it's multiple mechanisms.
Right. Could be a multiple connective tissue disorder type of thing. And that's interesting because I was just thinking about this. We've been doing this genetic series from a genetic educator we have. And everybody's been reading on the computer. They have this thing that says if you can do this with your hand and your thumb goes straight across, then you probably have a connective tissue disorder and you should be checked for an aneurysm. And I don't know how many people can do this, but I looked and I was like, well, I have 2 aneurysms, so I guess that makes sense. But this just seems like maybe it's not 100% accurate as a test. I don't
Yeah,
know.
Yeah, no, it's not. So I mean,
Okay.
specifically that's a test for one of the connective tissue disorders,
Right.
which is Marfan's.
Mm-hmm.
And Marfan's is a very interesting condition. We know the gene that causes it. We know
Mm-hmm.
how it's inherited. But there are so many mutations, and even the same mutation within a family can present differently.
Mm-hmm.
That Marfan's is a disease that is diagnosed clinically, and so one of the you get scores on skeletal features,
Yeah.
aortic features, eye features, etc. And of course, that's one of the tests that gives you points in that scoring
Mm-hmm.
system. But even a condition like that we know so much about is still really diagnosed clinically, isn't diagnosed genetically
Mm-hmm. Okay.
mostly. And so I think that shows you just how there's so much we don't yet know
Yeah.
about.
I tell people that I think if they're going to have genetic tests and it comes back unknown, go back again in 6 or 7 years when there's been more genes that have been discovered, right?
Yeah,
That's kind of where
very
I'm
good
on that path.
advice.
Yeah.
Yeah.
Um, Fact or fiction, there will always be an aneurysm present with a dissection.
Fiction.
Yeah.
In medicine, that whenever you get something that says always or never, you know it's unlikely
Mm-hmm.
to be true because there are
Yeah.
always exceptions. So
Okay.
aneurysms predispose you to dissection,
Mm-hmm.
but not all dissections come in aneurysms. And some people
Okay.
are just unlucky and have the dissection in a small aorta.
Right. Once you have, oh, we just talked about this. Once you have genetic testing, you're never going to have it again. And the answer is, well, you should consider doing it again after a
Yeah.
period of time. Okay. Um, Fact or fiction, you're at higher risk of an aneurysm if you have a bicuspid valve.
Yes, so we know that. We
Okay.
know that the bicuspid valve is associated with aneurysms in the ascending aorta and
Mm-hmm.
in the aortic root as well. Um, yeah.
So, um, can you have bicuspid valves in any of the other heart valves?
Uh, you can. Well, so there are 4 heart valves,
Mm-hmm.
and 3 of them have 3 leaflets, and one of them has 2 leaflets anyway.
Okay, so it doesn't
As
matter.
normal,
Okay.
the mitral valve.
Mm-hmm.
Um, but in the pulmonary valve, which is another, actually um, we call the mitral and tricuspid valves, which are inside the heart, we call those parachute valves. So
Mm.
they work very differently to like the aortic valve. They have
Mm-hmm.
strings and they work like a parachute.
Okay.
The aortic valve, we call that a semilunar valve. They're
Mm.
semilunar, half moon shaped leaflets. And
Okay.
the pulmonary valve at the bottom of the pulmonary artery is the same. It's a 3 leaflet semilunar valve, but you can get bicuspid pulmonary valves.
What would
The,
be the complication of having it there at the pulmonary?
so we don't usually notice a complication because
Hmm.
the pressure in the pulmonary circulation is so much lower. It's
Okay.
less than a quarter the pressure in the aortic circulation. So the
Hmm.
valve, even if it's bicuspid, doesn't usually degenerate at the same
Mm-hmm.
rate.
And then, so you'll hear a lot about people who have mitral valve regurgitation. I feel like it's a very common thing, probably very common as you age. And I don't really understand what that means. And even though we really don't talk a lot about heart stuff, but what does that mean because you don't really hear a lot about tricuspid, but it tends to be the mitral valve, tends to be
Yeah,
the problem
well,
valve.
it is a feature, for example, of
Hmm.
Marfan's disease that mitral valve, typically they call it mitral valve prolapse,
Mm-hmm.
but it's a form of mitral valve regurgitation.
Okay.
So that just means that those parachute valves,
Mm-hmm.
the strings of the parachute valve are not holding it so that
Okay.
it closes well. Typically, one of them is allowing the parachute to ride up and a
Mm.
leak to come in between the 2 parachutes.
Okay. And
So the mitral
how's
valve,
that fixed?
well, typically with surgery, open
Mm-hmm.
heart surgery, the
Okay.
best option is open heart surgery that can do an anatomical repair, and it's a careful surgical tailoring of those
Mm.
parachutes. There are some options if patients really aren't suitable for surgery. There is a transcatheter option,
Okay.
um, to be honest, it's not really as good. It's not an anatomical tailoring. It's you can clip the two parachutes together, and so it's a sort of a fix it,
Okay.
but it's not anatomical.
So when you repair it open heart, are you replacing it, or it really is just
No,
a
mostly
repair?
it really is repaired.
Oh,
And
okay.
those leaflets are operated on, and there are different. You can resect a bit, you can add a
Mm,
bit, and make it, or add more cords, more strings,
mm-hmm.
tighten the strings. You can put a ring around to stabilize the valve, and so mostly mitral valve is repaired.
Okay. I don't know. I'm of the camp that as much as I hate the idea of being cut back open and having open heart, I just feel like I'd rather have it all there so everybody has the whole visual scope of what's going on. And if there's a problem, you're already in there to fix it. Not that I assume there's lots of problems transcatheter, but I feel like I'd rather old school, tried and true. This is what we always did. I understand that this is new and fancy and it's doing really well. Just crack it open, just see the whole thing, get a lay of the land. That's just,
Yeah.
I don't know. I feel
I mean, obviously, I'm very
comfort.
much in favor of new technology and
Sure. Yeah.
advancing things for patients. And I want to give the best option to the
Right.
individual patient that's in front of me. Sometimes that is transcatheter,
Mm-hmm.
sometimes that is open surgery,
Yeah.
sometimes it's minimally invasive open surgery, sometimes it's robotic. We
So
have
many
now a
options.
whole range of options.
Yeah.
And that's why, for patients who are on this call, it's
Mm-hmm.
very important to go to a center where they can offer all these different options.
Mm-hmm.
Sometimes if you go to a center or an individual doctor and they only have one thing to offer, then that's the only
Right.
thing they're going to do. All the
Yeah.
problems will be solved with that one option.
Right.
And that's usually not the best thing for all patients.
Yeah. I agree. I'm going to check in because that's all of them, other than the last question, which I asked you before, which was fact or fiction. When I go on vacation, will I completely disconnect and unplug from Aortic Hope? And
I hope you do.
I hope I do too. I have one short meeting that is scheduled, but that's when the whole house will be sleeping. So by the time I'm done, they'll be awake and then we can go to the beach. So I did plan it the right way, but that means I have to wake up and I'm on vacation, but that's okay. Let me check in with Josh and let's see if there's any comments or questions from everybody.
Well, let's say hi to our new members of chat. Tony
Hi.
Montana,
Okay.
he says, quick question. I had a type A dissection and valve replacement pericardial with root reconstruction in September 2023. Was 52 when I had the dissection. Is TAVR an option with root reconstruction, or do I need another open heart surgery?
And no, TAVR is an option. Yeah.
There you go,
Your
Tony.
root will heal up and the TAVR can go inside that repaired root. Yeah.
Okay. Michael
Okay.
Smith says 11 years and still chugging along. Welcome to the chat,
Yes.
Michael. And
Welcome.
Elena says, hello. Should you
Hello.
have the CT scan always with contrast?
Uh, yes, I think so. You should always have the same type of imaging. If you're
Hmm.
monitoring something, you have the same imaging. If you're a young patient, you don't want to have a CT every year for 40 or 50 years. And if there's a degree of stability after, say, even 3 years, then you could move to a non-invasive imaging such as MRI, or you could extend the periods between the scans.
Yeah. Personally, I had a lot of CTs in the beginning, and I am highly allergic to contrast. So I've had breakthrough reactions, anaphylaxis. Like I save that if it's life or death, and then I have to be super uploaded with prednisone and Benadryl. So my annual scans are always cardiac MRI scans. Like I always have the same type of scan. Um, and there's never really been an issue. There's been fluctuation between numbers on echoes, and I eventually had to learn to just not go with anything that I read in the paperwork and wait for my surgeon to compare the pictures on top of each other side by side and let that person tell me if there's something I need to be concerned with, because you read these numbers and then you don't even know what you're reading in these numbers. Sometimes it's length and they screw up, and But yeah, I do MRIs all the time because I just, that's a lot of pre-medication, and I really need to save those for that life or death situation. So as long as you don't mind, I don't mind. I fall asleep in my MRIs. They give me those earbuds and I'm out cold. I start counting the sounds and then I wake up and the test is over. I find them unusually relaxing, those sounds. I'm just odd person. What can I say?
Good advice.
All right, Josh, anything else?
Let me take a quick look at the anonymous list.
Sure.
No, it looks like we are caught up in chat. Tony says thank you.
Oh, you're welcome. Look, we made this with 10 minutes to spare. Isn't that amazing?
Great.
I love this information. I really, really, truly do. And I love all of these answers. I really appreciate you sharing visually and sharing the information about the valves. I'm still going to have to sit here and weigh them out. But I know when the day comes, I mean, look, for me, having no change, having moderate to moderate severe irritation, I'm definitely symptomatic, and I've got two aneurysms that are like 4-3, so I'm not really worried. They haven't changed in many years. I think I'm hoping that technology keeps improving and changing, and we'll see when I need to have mine change. We'll see what options are available for me then. I've seen so many things just change in the last 10 years since I've been in this community, right? I mean, I never thought that people would even be talking about some of the things they're talking about. So yeah, I'm excited to see where it goes. What are some, if any, exciting things happening for you at your center? You doing 3D imaging? Are we doing AI stuff? Like, what's going
Yeah,
on?
so we're doing a lot of AI. We're big into AI,
Mm-hmm.
and 3D imaging is very helpful, but I think the AI is the bigger
Okay.
advantage for patients, and particularly patients who have scans for other reasons.
Mm-hmm.
It's really the AI that's going to picks up those cases. It goes through all the scans that are done at Cedars and can filter out patients who have had a scan for their lungs, who have an aortic problem, and highlight it to us.
That's pretty amazing. That's fast, is what it is. Super fast.
Yeah.
I like using AI when I get any kind of scan result. I know I just said I wait for the doctor, but that was kind of not really 100% true because I do like to know what the answer is. But I now just put the entire impression into Chat GPT and I say, please explain this to me in a lighthearted, comical way. And it does. And then it's not scary. And they're like, so you have an aneurysm and this is what it is. Picture this. And I just read it and I find it also entertaining. But I do think that it explains things in a way that's very easy to understand. And for somebody who likes instant gratification, it does allow me to just take a breather and wait until the doctor, gets around to
Yeah.
giving me a call. Because if there's something, we have each other's personal cell phone numbers because that's kind of how that's the attention I need. But I know they're only going to call, and I'm only going to call if we need to have a conversation today, type of thing. Like we're going to move forward with this. So yeah, I'm going to get used to this whole AI thing one day. I'm technologically a little disabled, but I'm getting there.
Doesn't sounds like you're technologically very advanced.
I'm trying. It's only because of Josh, because he points these things out to me and then I play with them for a little bit. And then, I'm not using them the way I'm supposed to, but I'm just, trying to have it's like when the internet came out and someone said you can put in anything. I was like, what does that mean? Put in anything. So I wrote down, show me pictures of flowers. I didn't know what to ask. And then I found myself there for hours on the dial-up computer, the one we had in the office, just asking silly questions that I used to find the answers to in like the encyclopedia, which nobody sees an encyclopedia anymore.
Yeah.
I am proud to say we have a complete set at my home. But yeah, I remember it's the same thing. It's like it's wild, um, infinite possibility area that's just too hard for my head to handle. So that's what you guys get to do. You get to enjoy all that. All right. If anybody has any questions for Dr. Catarino, you can reach out to us here at info@aortacope.org. I will get them over to you. And when you have a moment, if you want to answer them, that's great. You can also find some more information about him at Cedars-Sinai on their website. And again, thank you so much for joining us tonight. I do appreciate it.
Well, thank you very much for having me, and thank you to everybody for listening in and for your very interesting questions.
Yeah. Thank you, everybody. Again, don't forget, please click like, please click subscribe, click the bell so you're notified next time we go live. And I appreciate all of you. Have a wonderful evening.
Bye, and have a good holiday, Karen.
Oh, thank you.
Hey, bye for now.
Bye-bye.